Welcome to my Nut Physiology Research Part B presentation. My student number is 237741, and I'm going to dissect the critical appraisal of the research paper, The Effect of Low FODMAP Diet with or Without Gluten on Irritable Bowel Syndrome, a double-blind placebo-controlled randomized trial. The background of this research paper was regarding the effect of irritable bowel syndrome and the magnitude in which it plays globally, affecting around 11% of the population. IBS can present as in fluctuating symptoms as bloating, excessive gas and flatulence, mucus in the stool, digestive discomfort. It can impact quality of life and cause anxiety and fatigue, and a lot of abdominal distension. There has been growing evidence to support a low FODMAP diet to reduce symptoms. FODMAP meaning fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which are all carbohydrates that can be poorly absorbed in the gut and cause these symptoms. This study was a randomized control trial that was conducted in Iran, running from July 2020 to February 2021, and the aim to explore the impact and effectiveness of reducing or omitting gluten adjunct with a low FODMAP diet. The intention was to understand whether it was the gluten from either barley or wheat that were causing the IBS symptoms or the fructans from the wheat products. The methods: 63 subjects that had been recently diagnosed with IBS were selected, having to meet the age, BMI, and symptom duration criteria. The specific inclusion criteria meant that they had to meet the Rome 4 criterion of subtype IBS, IBS C, D, U, and M. The participants also need to have experienced these symptoms for at least 6 months. Additionally, they were excluded if they had a history of small bowel or colonic or gastric operations, any organic illnesses such as ulcerative colitis, and had any intense behavioral or mental problems, chronic colorectal diseases, and were taking any certain medications in the last 6 months. After a 2-week run-in on the low FODMAP diet, patients with no changes in IBS were excluded. The remaining 49 on the low FODMAP diet were randomized to a 5-gram gluten powder or a 5-gram rice protein powder daily for 6 weeks of the intervention. Adherence to a low FODMAP diet was assessed via 3 consecutive diet diaries, recalls on weeks 2 and 6. Outcomes were self-reported with data collected at baseline and at week 6. The primary outcome was the IBS-SS scale, and the secondary was the IBS quality of life, stool frequency and consistency. The results drew significant improvements were observed in total scores of IBSS. The abdominal pain intensity, frequency, abdominal distension, dissatisfaction with bowel habits, interference with community function, and quality of life in both the gluten and placebo groups were all assessed. Stool frequency and consistency improved only in the placebo group, while symptoms worsened only in a small number of participants in the gluten group. Adherence to the low FODMAP diet was assessed, and both groups showed adherence with dietary FODMAPs below 2 grams per day at weeks 2 and 6, indicating compliance with dietary recommendations. The study overall showed a non-statistically significant difference of 17% in the non-gluten group. In IBS scales between gluten and placebo groups, confirming previous findings that a gluten-free diet improves symptoms to around 20%, which appears to support the potential for non-celiac gluten sensitivity in this portion of IBS symptoms, with celiac disease ruled out. The authors state no significant difference in adherence to low FODMAP diet. However, Table 3 reports significantly higher intake in the placebo group compared to the gluten group of excess fructose at weeks 2, with a p-value of 0.019, and GOS at week 2 with a p-value of 0.008, and total fructans at week 2 of a p-value of 0.001, statistically significant, unlikely to affect the outcome. Total FODMAP intake was assessed to be less than 2 grams per day and at both time points. However, this study was not done with limited bias. So in the critical appraisal, there is minimal risk of attrition bias, which is good, though this could have been further reduced by performing the sensitivity analysis to investigate the differential loss between the follow-up and the gluten group. Double blinding is mentioned in the title and the discussion, but not further discussed in the methods, consequently risking potential performance bias. Outcomes was patient reported. Blinding of outcome assessors does not apply, and therefore there is no detection risk, which is good. Performance bias is marked as can't tell due to the lack of detail about how the interventions were administered. Data was reported for both groups at all time points. P-value between group differences, however, the precision effect, the 95% CI, was not reported, which raises a reporting bias. Using this